So, response assessment after chemotherapy, targeted therapy, and immunotherapy in lung cancer. So, views the criteria, response evaluation criteria in solid tumors, the current version being 1.1 for assessing response after chemotherapy. So, there are certain prerequisites for using this criteria, that the baseline CT scan should be done within 4 weeks before treatment, and the slice thickness should be at least of 5 millimeter, and IV contrast is mandatory. So the response should be assessed after at least 4 weeks and optimal is 6 to 8 weeks. Axial plane is used for measurement, and MRI can also be used, and FDG PET-CT is complementary. So the various categories you all must be aware of are progressive disease, stable disease, partial response, and complete response. So we have to define target lesions at the baseline itself. So any tumor with at least more than 10 millimeter in size, lymph nodes more than or equal to 15 millimeter in short axis dimension, and maximum we can select 2 per organ and total of 5. And we have to add the longest dimensions of all the target lesions for measuring. And it is prudent to mention series and image number in the report for further facilitation of comparison. And what are the non-target lesions? Anything which is non-measurable, pleural effusion, ascites, lymphadentic spread, leptomeningeal disease, bone lesions without a soft tissue component, any non-measurable lesion or a node, lymph node between 10 and 15 millimeter in short axis is pathological but non-target. So what is the criteria for progressive disease? For progressive disease, remember the comparison has to be made with the smallest sum of the longest dimension on the study. Now this smallest sum can be a baseline scan or immediately prior scan or any interim scan. So the criteria is more than equal to 20% increase, absolute increase of at least 5 millimeter, or a new lesion, be it measurable or non-measurable, or there is unequivocal progression of non-target lesions. So this is a simple case. You can see there is a significant more than 20% increase in the right upper lobe lesion. So this qualifies for a progressive disease. Now what is partial response? So partial response now has to be compared with the baseline study. We saw the progressive disease has to be compared with the sum of the smallest dimension of the study, whichever it is, be it baseline, interim, immediately prior, whatever. But the partial response has to be compared with the baseline study, and more than equal to 30% decrease qualifies for partial response. Nothing which is fitting into progressive disease or a partial response is stable disease, and resolution of all the lesions is complete response. So here you can see baseline scans, there is more than 30% decrease in the right upper lobe lesion, so this qualifies for partial response. Now in this scan also, there is a partial response. The left lower lobe lesion has significantly reduced, and the right lower lobe nodule has disappeared. But the reason I included this slide is to show you how to measure the lesion when it is associated with a collapse component. So usually you have to measure the lesion in the lung window. But when it is associated with the collapse component, then the hypodense part is the tumor which you need to measure, and the enhancing part surrounding it is the collapse. So addressing the dilemma. So if a lesion on a follow-up scan is at a location which is not scanned at baseline, then it has to be regarded as a new lesion. Once a lesion is target, you cannot keep changing the target lesion from scan to scan. You have to maintain that as a target lesion. Now, even if a short axis dimension of a lymph node falls below 15 millimeter on the follow-up scan, it needs to be measured if it was a target at the baseline scan. And if a target lesion has disappeared, then a default value, of course, you'll have to take it as 0. But if the lesion is too small to measure, then you have to assign a default value of 5 millimeter if 5 millimeter slice thickness is being used. Now, if the tumor has coalesced, then of course, the maximum longest dimension of the coalesced tumor you have to measure. And similarly, if the lymph nodes have coalesced, then the maximum perpendicular shortest dimension of the lymph node you have to take into consideration. Now, if a tumor from the baseline scan on a follow-up scan has fragmented, then you have to measure the long dimensions of all the fragments and compare it, add them and compare it with the baseline scan longest dimension. Now coming to bone metastasis. So both lytic and sclerotic bone lesions are non-measurable as per RECIST criteria. Only the soft tissue component, if it is associated with the lytic bone lesion, then it becomes measurable if it fulfills the target lesion by RECIST 1.1. That is, if it is more than or equal to 10 millimeter. and new onset sclerotic bone lesions suggest response and not progressive disease. But the most important criteria that we use, actually should be using for bone metastasis, is MD Anderson criteria. In MD Anderson criteria for bone metastasis, the lytic and sclerotic lesions are also measured, and they are also measurable lesions. So for complete response, if there's a complete sclerotic fill-in of the lytic lesions on a radiograph or a CT, or if there's a normalization of bone density on radiograph or CT, or normalization of signal intensity on MR, normalization of tracer uptake, then it's a complete response. And for partial response, if there's a development of a sclerotic rim or a partial sclerotic fill-in, or if there's an osteoblastic flare. Now what's osteoblastic flare? That none of the lesions, lytic or sclerotic, were visible on a baseline scan, and suddenly in the follow-up scan you see an osteoblastic, a sclerotic rim, and a sclerotic lesion. So provided all the other lesions show a partial response, this will be taken as a partial response and not a progressive disease. And if there's a 50% decrease in measurable, non-measurable, or a subjective decrease in tracer, then all these partial response. Progressive disease, if there's a more than equal to 25% increase in the size of the lesions. And stable disease not fitting into either. So this was a baseline scan, and you can see there is increase in sclerosis. So this is a case of a response and not progression. Now coming to post-targeted therapy for molecular mutations like EGFR or ALK. Now RECIST is based on size criteria. But many a times we have seen when there are molecular mutations like EGFR or ALK, the response is in terms of decrease in tumor attenuation, or there is increase in the cavitation, decrease in the solid component. So as of now, we do not have a separate response assessment criteria, and we still follow the size criteria of RECIST. But make it a habit to mention the qualitative features of response in the report as well. For example, there is an increase in cavitation, decrease in the solid component. Do mention them in the report along with your RECIST criteria. Now coming to immunotherapy. So after immunotherapy, there may be, what you can see is the much talked about pseudo-progression. Now what exactly is the pseudo-progression? So the tumor cells, they inactivate the T cells. And after addition of immune checkpoint inhibitors, the inactivated T cells get reactivated, and then they, in order to cause tumor cell death, they recruit more and more inflammatory cells, which leads to increase in hemorrhage, increase in edema, and increase in necrosis. Now because of this increase in hemorrhage, edema, and necrosis, there is increase in the false appearance of increase in size of the lesion, which is actually not due to the tumor, but due to the recruitment of the inflammatory cells. So this phenomenon is known as pseudoprogression. But remember, the maximum incidence of pseudoprogression is seen with melanoma, an incidence of 10%, and the next highest incidence is seen with non-small cell lung cancer, and the incidence being 5%. So the incidence of pseudoprogression is only 5% maximum with non-small cell lung cancer, which means majority of the progression that you see is going to be a true progression, and only 5% incidence will be of pseudoprogression. But we don't want this 5% of the patients also to lose the benefit of immunotherapy, and that's why immune response evaluation criteria in solid tumor was devised. It's a modification of the RECIST criteria. So what exactly is this now? So there is an addition of immune unconfirmed progressive disease category in this, which means that on a follow-up scan, if you're seeing 20% increase in tumor size from baseline, or a new onset target or a non-target lesion, then you have to categorize it into unconfirmed progressive disease and not directly label it as a progressive disease. But if on a follow-up scan, further follow-up of 4 to 8 weeks, there's a further progression of an increase by more than 5 millimeter in the target, or there are new lesions or increase in the non-target, then you can be sure that yes, so this is a confirmed progressive disease. So if the findings remain stable on a follow-up scan, then you have to continue using the term unconfirmed immune progressive disease until either it shows a true progression or there is response. So as I've already told you, this term IUPD has been given to account for pseudoprogression so that the ongoing immunotherapeutic drug is continued and not prematurely withdrawn unless progressive disease is confirmed on successive imaging or there is a clinical deterioration of the patient. So this is an example of a pseudo progression. These two are baselines. So you can see right upper lobe and left lower lobe, there's a lesion which has significantly increased on the follow-up scan and because after nivolumab therapy. So an unconfirmed immune progressive disease was given at this stage. On a further follow-up, again this goes back to the similar to the baseline study. So this was basically a stable disease and not a progressive disease. So this is a case of pseudo progression. Now there is something called as hyperprogression. Hyperprogression is when there is more than twofold increase in the pace of tumor progression after starting immunotherapy, and this is associated with worse outcomes. Whereas pseudoprogression is associated with increased survival. Now here is an example of a hyperprogression. So this is a baseline scan showing right upper lobe paramediastinal mass. So within 24 hours, the patient deteriorated and there was an increased ground glass densities that you can see in the right upper lobe. So within 72 hours, the patient presented with breathlessness and increased cough, and the CT scan showed profuse increase in the ground glass densities. So at this stage, this was after immunotherapy was given. So at this stage, a diagnosis of hyperprogression was made and corticosteroid was initiated, which showed resolution of the ground glass densities. Now coming to brain metastasis. So how do we assess response in brain metastasis? So we use response assessment in neuro-oncology for brain metastasis. That is RANO-BM criteria for assessing response. How is it different from RECIST? So in RECIST, if you remember, we can select maximum 2 lesions per organ. Whereas over here, we can select 5 target lesions. And contrast lens MRI is the preferred modality. And minimum slice thickness should be 5 without any skip. And what is a measurable disease? Contrast enhancing lesion which is at least 10 millimeter in longest dimension, visible on 2 or more axial slices, and at least 5 millimeter in diameter. It should have component perpendicular to the longest dimension. And non-measurable disease, anything less than 10 millimeter, ill-defined borders, dural mets, bony metastasis, leptomeningeal mets, and purely cystic lesions. So this is a simple case of a partial response. Here, more than 30% decrease. The criteria remains the same. It's just that you can select up to 5 lesions in the brain. That's the RANO-BM criteria. So this brings me to the end of the talk. Any question?